Hi there. Thanks for coming out tonight to be with us. And for those of you on Zoom, you're also welcome. It's so nice to be back here. I think the last time we gave a lecture here was in 2021 with a lot of caution at that time. But it's nice to just feel a little bit freer. Tonight, we're going to talk about GI issues. And this topic was chosen for several reasons. One, it affects both men and women. Two, it can affect you at any point of your life. And three, it's something that people don't like to talk about as much, so let's give it some attention. And four, it's also an area that we really could show how pelvic floor disorders overlap and how multidisciplinary care is so important. So tonight we have with us Dr. Cash Trivedi, who is a dear friend and colleague. We were fellows together at UCI years ago. And Dr. Lauren DeWinter, who is my professional partner, and Dr. Jenny Gablesberg, who is a doctor of physical therapy and has seen and taken care of many of our male and female patients. Their lecture times are actually very short, but we're really trying to show how this weaves together. And as Rose said, there'll be a question time at the end, and we want to address as much of that as we can. So thank you for being here.
Let's see. Hello, everybody. I see some familiar faces here, some unfamiliar faces, and hello to everybody on Zoom. Yeah, so my name is Cash Trivedi. I'm a gastroenterologist. I think I'm going to put this a little away. I'm a gastroenterologist in the community here in Los Alamitos with comprehensive GI care with Lisa Hertz and Dr. Lisa Hertz and Dr. Pavan Monkal. And thank you, Rose, and the pelvic floor team for having me here today to talk about GI issues and how they overlap with some pelvic floor issues. So, I don't have any financial disclosures, and, this talk is just for educational purposes only. Obviously, talk to your provider about specific issues, blah, 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 usual disclaimer. Okay, so first I wanted to talk about what is the pelvic floor. And the pelvic floor is a set of muscles, nerves, ligaments, and connective tissue that support these organs in the pelvis and allow us to defecate, poop, and urinate, go to the bathroom. Apologies in advance. I know people are enjoying like the treats and stuff over there. Me talking about a lot of poop. So I'm a poop doc, what can you say? Here I have a cross section. This is a cross section of maybe a schematic of women's anatomy, and I don't mean to exclude men, but outside of the organs that are female, right, like the uterus and all that, some of these things are good. These things are going to apply to men as well, all right? So the organs of note here are the bladder. In women, the uterus. Men's prostates obviously are going to be here. You have the bowel, and specifically, this is the rectum. This is behind, and the pelvic floor is this sling that is here. Now, you have this little tube here. In this, I just kind of made a little target. This is the anus, the anal sphincter. And you have the external anal sphincter, and you have the internal anal sphincter. And the external anal sphincter is under voluntary control, so when it's time to go, you go. The internal anal sphincter is not under voluntary control, okay? So that'll be important later. All right, so how can we think about kind of normal bowel function here? Well, first, you don't need to go, all right? You don't have it. This stands for rectum. So this is your rectum, which is all the way at the end of the colon. Colon is the large bowel, and the rectum is probably about, 5 inches, roughly 4 or 5 inches, plus minus. So you have the rectum here. Now the end of the rectum is actually pinched closed all the time, all right, by this muscle here called the puborectalis. And there's other muscles here, but the puborectalis actually pinches it closed. So that you're not just leaking stool all the time, right? And then you have your sphincter, your anus here, external, internal anal sphincter. So you don't need to go, you're walking around, you're enjoying your meal, whatever. This is the way it is. But now, think I need to go soon, right? You need, not me, but in general. So you got to go soon. So this is my depiction of stool. So stool's starting to come in here. Now your puborectalis sling, which is all the way at the bottom, one of those pelvic floor muscles, is still tight. But now what's going to start to happen is your internal sphincter is going to start to relax. It's not under voluntary control, but your external sphincter, which is under the control of you, your brain, is saying, nah, not ready yet, not time, all right? And they're like, okay, I found a place, now I'm going, all right? All right, so what's happening here? Well, is it still, okay. So the rectum then starts to contract, so that means squeeze. This puborectalis sling now starts to loosen, so it starts to not make the rectum less kinked, and the external sphincter is now relaxing, right? So you're like, oh, okay, everything's relaxing, I'm going now. And this is ideal, right? So that's you're going, all right. Now, what kind of symptoms do I hear about when I'm with patients? And then I'm listening to these problems and it makes me think there may be an underlying pelvic floor problem. Well, the biggest thing is straining. I got to push really hard to go. Or I push and nothing really comes out. There's a lot of pain in that rectal or anal area. You have the urge to go, but you can't go. And crossover with some urinary issues too. Like, hey, I have trouble peeing and I can't really pee. Recurrent UTIs means urinary tract infections, right? So sometimes people with recurrent urinary tract infections actually have a bowel issue. And this is a very common one. Like what they'll comment on and just says, hey, this is not important, but every time I pee, I poop. All right, well, we're gonna get to that. Now, people all often, and they don't often volunteer this because this is people are embarrassed about it legitimately, but they'll have leakage or incontinence of stool. So pretty much there's so many gastrointestinal issues, right? And it's like this big black box. But really the things that I'm going to focus on today as it relates to the pelvic floor are these two main things: constipation and fecal incontinence. I'm going to talk about belly pain. I'm not going to talk about pelvic pain. I'm not going to be talking about reflux as much, but I'm going to be talking about these two things. Okay, let's talk about constipation. Well, there's a definition, right? It's like less than 3 bowel movements a week, hard, dry, or lumpy stools, or feeling that not all stool is passed. But here's the real telltale sign. Everybody's definition of constipation is a bit different, right? People don't read textbooks and they come to you saying that, what they'll say is, I'm not constipated. Well, tell me in a week, how often will you go? Maybe once. I'm not constipated, but man, I push and strain and you know what comes out? Toothpaste, So I want you guys to realize that when we use the word constipation, it could also mean just not emptying all the way. And so it can be a very unique definition to everybody. And these stools can often be soft or even loose. So you can be backed up and it'll just be really loose. So it's very common. Now this right here on the right is something called the Bristol Stool Scale. It's like the poop chart. Every time I give it to somebody in the office, they laugh and like, oh, it's everything, doc, But this is one way. These are very, very hard stools at type 1. Type 7 is very, very loose stools and things in between. So it's a way for us to document like, okay, where do you fit on this pattern when we get a history? All right. So let's think about what pelvic issues may lead to constipation. I'm looking at the whole pelvis now. And I think sometimes for me, anatomically or top to bottom or bottom to top makes sense. So you'll see me kind of bringing that up a bit. So let's start top to bottom. You've seen this schematic before this. So some of the issues that can lead to constipation, or let's just say incomplete emptying or whatever definition you use, is around this rectum, the walls here, the walls are weak. Okay, so that's one thing to think about that could lead to not emptying all the way. Another thing is, well, the walls may be okay, but your pelvic floor is just not relaxing appropriately. These muscles like the puborectalis and the other things may not relax. And then the other thing may be, well, all the way at the bottom, the anus may be really inflamed or maybe blocked for some reason, okay? So these are sort of the overall things to think about, and I'll go into some specifics in a bit. All right, now I think Dr. DeWinter is going to talk more in detail about this, but some of the things that we do see when it comes to that rectum and that wall, well, what specifically are we looking at? Here again, this cross-section of women, I don't want to be biased against men, but you know, here, this is where we are. What we have here, and I don't know if there's, so the the rectum here is this, and I'm talking about these walls generally right here. So there are these terms that you'll hear. You'll hear the term rectocele, enterocele, and sometimes we also see this too, rectal intussusception. There's also rectal prolapse. I think, again, Dr. DeWinter may address that a little bit more. But these physical entities can exist and lead to incomplete evacuation or constipation, okay? All right, so I got to thank my son there who helped me actually get the drawings to Google Slides, because clearly the older I get, the less I know how to type and deal with technology. All right, so here's kind of normal anatomy. Again, female anatomy, could be men, but mainly female. Here you have the uterus, and here you have the vaginal canal. I know V's over here. And here would be the rectum, here's the spinal cord. So normally, poop would be here. Here's the anus, like stools in the rectum, all the way at the bottom. Now, in a rectocele, what can happen, though, is because of chronic straining, having kids, getting older, weaknesses in the rectal wall, instead of stool being able to come out, there's a pocket that forms, often towards the front of the rectum, but it could be backwards, and that poop can get stuck. So what do people say? It's like, I got to wiggle a lot. You know, I feel like I need to go, but I can't go. And, you know, I mean, it's kind of embarrassing, gross for some people. It's real. Sometimes I got to get a finger and get stuff out of there. Or you got to take fingers intravaginally and push to get the stool out. So when I start hearing those things, I think, you know, maybe this person has a rectocele, maybe has this pelvic floor problem. Another thing that we do see sometimes is called an enterocele. Again, here is a normal, quote unquote, normal schematic. But in an enterocele, it may actually be the small intestine that's falling through the septum, the rectovaginal septum. Septum means like a barrier, I guess, a membrane barrier. So instead of the rectum and the vaginal canal being close together, there's actually small intestine that's fallen in between. And as you can see, it can make the rectum narrow. It can kind of squeeze this thing over. It squeeze the rectum so stool can't come out. Now, rectal intussusception is where one would have this situation. It's like maybe the rectum over time has gotten so big and floppy that it just sort of folds over on itself, almost like telescopes on itself. So essentially, when somebody pushes, those walls come down here and the poop just gets stuck above. Okay. Now I will talk about later, but a lot of times all three can be happening at the same time, in addition to other seals, like a cystocele and whatever. So it can get really complex, and that's why, you know, the pelvic floor therapists and the urogynecologists here, that's why, you know, it's really important that they get involved when they find this kind of stuff if it's an issue. All right. So we're talking about the rectum, right? The top part. Let's go to the middle part. Sometimes that sling doesn't relax. And more often I see is where the sphincter, it doesn't relax. Remember I said, like, you know, when you're trying to go to the bathroom, your internal sphincter is already relaxed, but then your external sphincter relaxes when it's time to go? Well, you know what happens sometimes? There's something called dysinergia, which means, you know, abnormal, sort of like an abnormal function. So instead of it relaxing, it may do nothing, or the sphincter may actually squeeze. So what happens? Essentially, you're pooping against a closed hole. That's pretty much what I tell my patients. So why are they straining and stuff? This may be the issue, okay? Let's go even lower. So remember I talked about the anus all the way at the bottom? If you have these hemorrhoids, these are internal hemorrhoids, which bleed and get big and bulge. And then you have external hemorrhoids in some people, which often can cause pain. If they get really big and really inflamed, they can then affect this area here, so you can't really empty. The area is always like inflamed and squeezing all the time. Same thing with fissures. Fissures are small little tears that can happen in the sphincter, and that can happen with pressure. It can happen with constipation, so that delicate lining in the anus can get scratched. Sometimes, I think men are probably more likely to do this than women. It's like, my bottom is like hurting quite a bit, and I look and it's like, my God, it's like destroyed. And the reason is sometimes men are just like, they wipe. They get really forceful when they wipe, and they can cause a lot of fissuring and trauma. And essentially that causes pooping against a closed hole, right? All right, so we've talked about constipation a bit. Let me talk about this thing, fecal incontinence, okay? So fecal incontinence is involuntary loss of stool. Why? Well, sometimes there's just a ton of loose stool and diarrhea going on. Maybe somebody is eating 17,000 Splenda packets a day. Or they grew up in Wisconsin and cannot give up milk and are drinking half a gallon of milk a day, and clearly they're lactose intolerant now. Or there could be an infection, or maybe other kind of illness like irritable bowel syndrome, or more like inflammatory bowel disease. And on top of that, there could be something else, like maybe getting older, the tissues are getting a bit weak. And so there's just too much stool for the rectum to deal with, and so there's leaking that happens, right? Another thing that can happen is maybe the rectum is okay, but then there's a sphincter problem. Maybe there's all this inflammation from hemorrhoids, maybe there's fissures, maybe there's both. Maybe because of childbirth and vaginal delivery, there are big tears that happen, where sometimes you can have tearing that go actually through the sphincter, or there's been some kind of trauma through the sphincter, and that actually disrupts this anal sphincter, and that can cause things to leak. But commonly, what I often see is this problem, overflow. Hey doc, I can't, I'm having leaking and whatnot, but it turns out they have so much poop in the rectum, only the liquid stuff goes around. And that liquid stuff is then difficult to control. So because they've been popping 10 Imodium a day, they're so backed up, only the liquid comes out. And I see this mainly in patients who are older and people who have maybe had a history of stroke and that kind of thing. But it's very common. All right, so how do we do it? So how do I get down to try to figuring out what's what here, all right? Well, I asked those questions about constipation, like the straining and the pushing and the maneuvers and all that kind of stuff. So I asked about constipation, fecal incontinence, and the stool consistency, like the Bristol scale is helpful. We talk about these kind of different maneuvers. I try to go through the diet and medications, especially dairy. Some of my most difficult causes of fecal incontinence turned out to be lactose intolerance. So that, celiac disease, artificial sugars, medications that can cause constipation or diarrhea are really important. What I also note too is like maybe the timing of some pelvic surgeries and symptoms. For example, I've had a number of patients who have undergone prostate surgeries in men, but then because of the procedure, not that nothing went wrong with the procedure, but because of the proximity around the opening of the rectum, they can't go to the bathroom. So that can be related. And then the urinary symptoms I've mentioned here as well as belly and abdominal pain and bloating because they're really distended, because they're not going to the bathroom. The abdominal exam can be helpful, really helpful for me, as well as a detailed rectal exam in the office. And if the above doesn't give me enough information, there are two tests that we do. One I do in the office, the other one is an X-ray. It's called the defecography, and let me briefly look at that. So anal rectal manometry. So this right here is a probe that we do in the office, and it's a test to get a sense of whether or not somebody may have dyssynergia, which is that coordination problem in the sphincter that can lead to kind of pooping against a closed hole. And it can also give me information about sensation in the rectum, because there's a little balloon at the end of here, which we can gently inflate to see if patients can feel it or not feel it or are hypersensitive to it. So in my practice, this has been actually quite helpful in figuring out, if people are having issues with that. I think I'm missing a slide here, but I think there was one here on defecography, so I don't know. But defecography is essentially an X-ray where people consume contrast, and then it's kind of embarrassing, but helpful if people get to that point where they try to actually go to the bathroom while the X-ray is being done. And then that's one way you can really reveal to see if you can have a rectocele or cystocele. Again, not something people would really readily sign up to unless they're getting paid a lot of money. But sometimes people are to the point where like, hey doc, whatever you need to do to help me get better, it's fine. So it's there. All right, basic stuff. Let's look at bottom up in terms of constipation, how we deal with that. For hemorrhoids and fissures, fluid and fiber, right? None of this stuff is rocket science. Some over-the-counter preparations to decrease the hemorrhoidal size, and there's some creams and ointments and suppositories we give people to help with fissures. Big fan of the bidet. Yeah, we're a bidet family. My son, I don't want to embarrass him, but I will. When he was 5 years old, he was using bidet. Dad, this is great. Okay, bidet is great. Wipes and stuff to kind of decrease trauma. Now, internal hemorrhoids which bleed can be banded. So rubber bands can be put in there. Don't have to do that often. Surgeons sometimes do Botox for fissures, and very rarely some surgery is actually required, okay? Dyssynergia, that issue with kind of going against a closed hole. And this also kind of includes the puborectalis spasm, that sling that's tight. Well, that's where our pelvic floor colleagues are so helpful in terms of being able to do biofeedback, whether manually or actually using a computer attached to like a sensor to get patients to retrain their brain and their sphincter to be able to work appropriately. And then when you have these rectoceles and other weaknesses of the rectal walls, so we're now at that top area, in addition to fiber and fluid, sometimes you need laxatives to get things to go. And topical stuff like enemas and suppositories can help temporarily, but who wants to do those every day, right? That's where our urogynecological colleagues and our pelvic floor colleagues can be really helpful too, because, and they'll talk about this more, but looking at pessaries, there's a special kind of pessary, I guess, called the Eclipse device, which Dr. DeWinter may address, and then actually surgical repair, okay? For fecal incontinence, is this a constipation issue? I ask that. Is it a diet issue? Is it infection, inflammation, or a medication issue? Or is it a rectal spasm issue? Okay, there's something called sacral nerve stimulation, which sometimes can be helpful with rectal spasms. But once again, it's all kind of in the history because this can be very complicated. I'm giving you a lot of information, but pelvic floor PT can be helpful for strengthening the sphincter, soluble fiber to kind of bulking up the stool. Sometimes antidiarrheal medications can be helpful, and sometimes people need repair of the sphincter. Again, not very often. All right. So in summary, problems with the pelvic floor, and the pelvic walls can lead to constipation of fecal incontinence. And diagnosing those issues, and they can be really complex. I mean, I do this day in and day out, so for me, it's just very intuitive, but having to do this on your own is really hard. And there are a lot of treatment options, and they're involve multiple specialties, okay? And, it may take time, things may not be perfect, but we can get a lot of people better. With that, I'm gonna end here and pass it off to my colleague, Dr. Lauren DeWinter, one of the urogynecologists, to talk about special concerns for women. Thank you.
Perfect. Yeah. Well, welcome everybody. This is probably not what you thought you were getting into tonight, but I applaud you for staying with us. We appreciate it. I know bowel is has a lot of feelings around it, and women have. It's an embarrassing problem to have. It is a hard problem to find the right doctor for, and a lot of women don't seek care for their pelvic floor problems. And so I'm really happy to talk with y'all tonight. So if you don't have these problems, if you have friends that have this problem, just let them know that they can seek care somewhere, right? That there's options for this. So I'm going to talk a little bit about how women's bodies obviously are a bit different than men's bodies, all the way from the first time you have a period all the way through menopause and to the end of life. And so when women are young, we all already start having bowel problems compared to men. So women, when they have their periods, hormonal changes can change how their bowel function is. Endometriosis can cause constipation, and then they have a period, and then they get diarrhea. Irritable or IBS, which is irritable bowel syndrome, is twice as common in women compared to men. And we think it's probably somewhat a hormonal mediated reason of how fast your bowels move and what goes on at the distal end. And so just from the get-go, women have a little bit different things that are going on in their systems compared to what men do. Once you have a baby, that completely changes things, right? Because the pelvic floor has to go through this very dynamic, very intense experiencing of opening up and giving birth to a baby. The pressure is applied to the pelvic floor. Some of those muscles get injured or damaged. Nerves can be stretched or they can be damaged at the time of vaginal birth. And then right at the end of your vagina, right next to it, is your colon, like he spoke about, right? So your mechanisms of control for your bowel are all really very, very close to where a baby's head comes out during birth. And so when there's tears in those areas, it makes a huge difference in what kind of control you can have. So men and women, by the end of their lives, by the time you're in your 70s, 80s, 90s, the rate of leaking of stool is about 9%, regardless, male, female, all of the above. But women, when they're young, 20s, 30s, 40s, a lot of times will already have fecal incontinence when men get it a little bit later in life because of those injuries that happen with birth. And then after birth, and sometimes even if you haven't had a baby, women get something called vaginal prolapse. Vaginal prolapse is those organs, it's a hernia. It's your bowel, your bladder, your uterus trying to fall out of a potential space, which is the vagina. And when that happens, it changes how your bowels work, how your bladder works, and it can affect control. And I'll show you some pictures. So this is for your normal pooping, to have a normal bowel movement, you need three things. You need squish, it needs to be soft, right? It needs to be the right consistency. It needs to be able to push, and that it needs to move along. Not that you have to push at the end, but that the bowel is moving along the tract like it's supposed to. And then my favorite is tush, because right at the very end, you need to have that tight control at the end to make sure nothing leaks out. And so there are these Bristol stool scales, which I think are hilarious, but I kind of circled or highlighted the 3, 4, 5. I tell women that what they're going to shoot for is kind of like mashed potatoes is kind of a goal. That's the sort of right consistency that moves along really easily, that you don't have to push and it comes out at the right time. That works for women that don't have bowel movement problems usually, and women that have prolapse and other issues. So the poop consistency, as he talked about, depends a lot on your diet. That's not a lot different for men and women. It doesn't seem to matter a whole lot. Women's diets are pretty similar to men's. The issue with consistency is when you have prolapse and that poop gets to the very, very end of your colon and it sits there a long time, water is pulled out of it aggressively. And so you start getting into let's see if I can do this, the type 1, type 2, you start getting the lumpy, hard, like stools where you get part of it out and don't get all of it out. And it's because it's kind of been sitting there too long. And so you can't quite get that last little bit out. And a lot of times it's because of that prolapse or pelvic floor dyssynergia, those other conditions we talked about. The next thing is push. So you have to make sure that the speed of everything is moving along at a consistent pace. And that gets disrupted when nerves are damaged, childbirth, when the anatomy changes or goes to a different direction. And so even if you had normal bowel, it doesn't mean that it's going to move normally if your anatomy changes locations. And tush, this is an AI generated anal sphincter. You're welcome. I couldn't find a not creepy one online, so I found this one. So it has the different rings of, this is what the internet thinks of an artistic anal sphincter. And so each of these are the internal anal sphincter. You can kind of see here if you were going to do an ultrasound. The external anal sphincter is here. And so imagine the vagina is up here. And so when you give birth, you get a tear through these layers of the anal sphincter on the 12 o'clock spot if it was a clock. So this all kind of sets the scene for what happens for women. So in a normal pelvis, you've seen a bunch of pictures of a cross-section of anatomy. So the front of the body is off to the left, the back of the body, the butt, is off to y'all's right. And so in a normal, a normal lady, everybody's normal, but sometimes anatomy is different. But when you're born, you have everything is sort of in a straight line. You got the front, the middle, the back. And so when you get something called a rectocele, you end up with that big bulge and the poop gets stuck. It pushes on the vagina, it pushes on the bladder, and look where it pushes on the bladder at, right where it's at the neck. Like he said, you can actually get urinary retention or inability to pee because there's poop that's pushing into those organs and blocking your ability to go to the bathroom. So it's not just your bowel that gets affected with this, it's also your bladder really commonly, even if you don't have a bladder prolapse. And so this is the normal way we looked at, right? Oh, did it not have my arrow on it? No. Okay, there was supposed to be an arrow that it was animated. Don't worry about it. We're gonna show it here. So basically, you have a straight shot. It just goes straight out the butt. We know we have the puborectalis here that relaxes and that helps it straighten up. But whenever you end up with prolapse, you have a totally different exit. I'm gonna go walk over here. Maybe not. This is going really badly. Okay. So unfortunately, whenever you have this, you have two different issues a lot of times. So it has to come this direction, and then it has to come this direction, and then it has to come out this direction. And this ball of stool just gets stuck right here, which is really upsetting for people. So one of the things that women will do, this is the vagina tube right here, they'll stick their own finger in and push down. And that helps poop come out because it straightens out the colon. It actually is a really effective way to do it. It also pushes on the puborectalis muscle and makes it relax. And so between the two of those, some women are able to poop like that. There's apparently also some sort of device on Amazon that my patients keep picking up that they can put like a paddle in their vagina and push back so they don't have to use their own finger. What is it called? The FemEase, you're welcome. I did not know this existed until recently. So I think that there's a lot of things that women are doing to get around this problem, but not actually fixing it because they don't know what to do. I'm also going to talk a little bit about the effect of vaginal delivery before I talk about how to fix this. So vaginal birth is really intense on the pelvic floor, as you might expect. So just ignore all of this. The birth canal is sitting right next to the bladder. Baby's head's right there, and that's right where the perineal body is. There's supposed to be this big explosion right there that did not come through on the slides. That's okay. But basically, look how thin this little membrane is between your vagina and your anus, and how big a baby's head is. And so, unfortunately, 10 centimeters of a baby's head, diameter-wise, can often make tears between those two areas, which is what sets you up for a rectocele, and it's what sets you up for an anal sphincter injury. Because this wall right here gets stretched wide to accommodate that baby, later on that turns into a rectocele, that turns into pelvic organ prolapse in the future. And then right as the baby's head comes out, it can rip that anal sphincter, that tear it, the psychedelic one I showed you before. So I also found these on AI, don't worry about it. So the big, I agree with Dr. Trivedi when saying that constipation and bowel leakage, which is fecal incontinence, are the two biggest things that my patients have concerns about. That is, unfortunately, it looks very much like me, and it bothers me a lot, but I like so I know. That's why I had to have it. So anyway, constipation can happen because of a rectocele. It can happen because of dyssynergia. It can lead to hemorrhoids. All of these things kind of play off of each other and are in interplay with each other. And so that's a very common complaint that I take care of. There's also bowel leakage. That's what it said when I looked for brown pants. But anyway, there are things that we can do about this, right? Like, this is not that you have to just live with this for the rest of your life. You don't have to struggle and sit on the toilet forever. You don't have to drip bowel contents on accident or rush to the toilet all the time, right? There's surgical repairs, so that bulge can be tucked back in with stitches. It's our best surgery of all the prolapse that we can fix because it works about immediately, and it only has a 7% failure rate, meaning you fix it and the rest of your life, 15, 20 years down the line, there's only 7% of women that get that back again. It's our easiest compartment to work on, so we're really happy, and people are like, oh my gosh, I can poop and it's normal. I'm like, I know, that's how it's supposed to be. There's also what he talked about was fixing the anal sphincter to kind of help with leakage, which is a sphincteroplasty, and that's putting those sides of the anal sphincter that tore when you have a baby and putting them back together. The best time to fix that is right after birth, but if it doesn't, you can put them together later on if it's really, really bad and very, very wide. And the last thing is sacroneuromodulation. I don't think this is something that people have talked about very much. It's basically a bladder and bowel pacemaker. We used it first for overactive bladder, but we found that women that had dual incontinence, meaning urine and poop that leaked out, they had this amazing response when they used it for found out that on accident, they weren't leaking stool anymore. And so it's something that the incision is a couple of centimeters in size. It's an outpatient procedure, and women do fabulously with this, even if they've had bad tears, even if they've had a lot of other things in the past. And the batteries now last 15 years, which is incredible. And you can get MRIs with them. And so there's these things out there that are so minimally invasive for something that gets women out of their house, that gets them to not be isolated anymore. They work for men too. Men also use that sacral neuromodulation. It works for men just the same as it works for women. There are medical things that we do that he talked about, dietary changes. Pelvic floor PT is incredible. Like, I think every woman needs to go to pelvic floor PT, perhaps, exactly. Like, after birth, everyone should go, and they should get acclimated, like figure out what's going on in their own body, is what my opinion is. But for bowel issues, they're incredibly effective. A vaginal pessary is a circular ring-shaped device. It's made out of silicone. You slip it in the vagina, you wear it, you walk around, do your thing. You can leave it in for up to 3 months at a time, sometimes 6 months based on recent data. And it just sits there and it holds your bowel down. You can take it out if you want to, you can put it back in if you want to, or you can have a doctor manage it. But it's something that's not surgery that you can do to help your bowel function get back to normal. It's fit, so there's different sizes, and we fit them for women all the time. You wouldn't even know that somebody has one. And the last thing, bowel medications are an option that he talked about. That very last thing I want to mention just before I get finished is the Eclipse device. So my partner fits them. I can't even get in to get the training for it because of the pandemic, but she was on one of the original studies for something called an Eclipse device. It's a non-surgical treatment for bowel leakage for women. It acts like that plastic pessary that goes in the vagina, but it has a balloon that you fill up with air and it compresses the rectum, and you undo it when you want to have a bowel movement, and otherwise you don't leak. And for women that have been isolated and stuck in their house, it's been a game changer for them, especially the ones that don't want surgery. So I just want to say that for anybody that's dealing with these conditions, go to someone that knows how to take care of this. Have them do a pelvic exam on you if you have any of these complaints, right? A lot of doctors don't look at your vagina, but there's so much going on there that you're going to miss if they don't look. And next is Jenny Gablesberg.
That's it, right? You did say it right. I married into that one. I started with Johnson. Easier. All right, I'm coming across. For guys in the back, you're trying to follow me around. Back and forth. My name is Jenny Gablesberg. I'm a physical therapist. I think probably when you think about a physical therapist, you think, oh, I had somebody help me with my shoulder surgery, or I hurt my back, or I had an ACL repair, or I sprained my ankle. Well, there are those of us who don't do general orthopedic things like that. We do after graduate school education on pelvic floor disorders. So I've been a pelvic PT for about 28 years. I teach classes to other physical therapists as well, and I help run a residency at my own clinics. I have a clinic in Long Beach and a clinic in Florence. Yes.
Do you mind speaking in the microphone? Our guests who are on Zoom, could you hear me?
I
know, and it's really good stuff.
I know. Okay. I know. Yeah. I feel a bit like a game show host when I've got this going, and I'm used to using my hands a little bit more, so this throws me off my game a little bit. All right. So when we think about what a pelvic health physical therapist or occupational therapist does,
We are looking at basically challenges in the organs. So we look at bladder dysfunctions, we look at bowel dysfunctions, which we're mainly going to talk about tonight. We take care of prolapse concerns, and we also deal a lot with pelvic pain. That could be pain with penetration, it could be just pain sitting, but it's all pain kind of in this pelvic region. So Dr. Trivedi stole my thunder a little bit with the pelvic floor anatomy stuff, so you're gonna get still a little bit of a review. So if you think about where your pubic bone is and where your tailbone is, and then if you kind of bounce side to side a little bit, you're gonna feel your sits bones. We call them your ischial tuberosities. The pelvic floor muscles are a sling front and back, side to side. And there are 3 layers of those muscles. The most superficial muscles help shut the openings. The intermediate muscles kind of go around as sphincters around our canals. So they keep the canals long and thin. And then the deep layer are this nice sling, that puborectalis or pubococcygeus that Dr. Trivedi and Dr. DeWinter were talking about. That third deep layer is what helps keep all our organs lifted where they belong, okay, which is where we would love them to be, but they don't always stay. Okay, so in talking about pelvic floor, that is kind of this picture here on the left, that sling keeping all your organs shut and all your organs lifted. But as therapists, we don't just eyeball directly into the pelvic floor. We need to look up into the diaphragm and even all the way up into our glottis. So we're looking at pressure canisters. And the big one that we're gonna start with is thinking about your diaphragm, okay, hidden between your ribs, down to your pelvic floor. That would be your top and bottom. And then the front side is the deep belly muscles, the transverse abdominis. And in the back is our deep back stabilizers called our multifidus. Those 4 muscles should work together like they're best friends. Like they're little girls running on the playground, hand in hand, like going everywhere together. We want them to automate. So if I go and I cough, my pelvic floor, my transverse abdominis, and my multifidus should kick in before I cough. My brain knows it's happening, and it says, I'm going to keep everything stable and tight and supported. You're not going to leak. You're not going to have any organs drop out, right? So there are things that change that automation in our brain. Dr. Trivedi talked about training the pelvic floor and the brain to be talking to each other. And things like pregnancies, growing and birthing a human is a big job. Any abdominal surgeries, spine surgeries, could be rib fractures, it could be lung radiation, anything that is impacting the way that we manage pressures can change what's happening in our pelvic floor because it tries to help. It thinks it's a helper. So sometimes that means it gets too tight and holds too much. And then sometimes it takes the brunt of all those pressures. So as physical therapists, we used to always think diaphragm to pelvic floor, like this is the main thing we need to be fixing. And then a pediatric cardiopulm physical therapist really started diving into the research of, well, what's going on up here, up to our vocal cords? So between our vocal cords and our diaphragm, this is our intrathoracic pressure, and it moves basically in opposition of our intra-abdominal pressure. And our diaphragm's in the middle. It's going up and down. So we need to look at functionally how our patients move, and does that impact some of these things like leakage or constipation? So we have those 3 main muscles that you guys have heard about a little bit, but I'm going to do a little visual demo because I think that's more fun. Katie, can I borrow you? So Katie did not know she was being chosen to be our rectum today. That means you have to put on the hat. She is our rectum. Oh, perfect. Oh, you look so cute. All right, so I want you to just hold your hand like this. All right, so we have an external anal sphincter. Phew. And so now we have an internal anal sphincter. Probably should have put that guy on first. There we go. So I'm going to back up a little bit. Our lovely rectum. We have the rectum, and then there's this corner that we saw in the pictures. So this is the anal canal. Okay, rectum where everything is stored. Oh, you got good muscles. We got good poop in there right now, or constipated poop in there right now. And then we have this anal sphincter, and there's this kink there. So we have external anal sphincter, we have internal anal sphincter. And then that muscle that you've heard about, the puba rectalis, keeps this kinked. So you should be able to go about your day and not leak. Okay, this is the exact same anatomy in our female-bodied and our male-bodied patients or people in the audience. And so this is lovely. We like all these muscles to do what they're supposed to do. But if this is too tight, give me a really good angle, it might be really hard to get that stool out. I'm making her work hard. She's gonna show off her stool muscles. Good. And now, if this is really weak, or this underwent a very big 10-pound baby, yeah, you knew where I was going. Now we're not kinked anymore. And maybe some stool, if it is softer, is going to just slide on out. Okay? All right, you get to stay put for just one more second. We're going to talk about a reflex that happens here. If you were to guess, what is the smartest muscle in the body? Anybody? Okay, the heart I like, but no, not what I'm thinking right now. Anybody else? The brains? No. It's the internal anal sphincter. It is so cool. No other muscle can tell you the difference between liquid, solid, or gas. Who knew? Right? So, stool is decided to come down. And this little thing, we call it the rare reflex. So a little bit of stool comes down, and we get some sampling. It's like a little taste test, right? So this little bit comes down, and the internal anal sphincter goes, what is this? What is it? What is it? What is it? And say it's happening right now. And you're like, oh, that's gas. So I'm going to tighten this guy back up, and I'm going to wait, right? Or you're going to hope. You're going to wait. Anybody got any teenage boys in the house? They don't wait. My 16-year-old, just wait till this one, who's 5. Just wait. Okay, so if this is solid, it tells you, okay, there's poops in there, but you're loving this lecture and you don't want to get up and leave. So these guys tighten back up and they say, oh, you've got to wait. Hang out, not time. You can go later. But if this stool is too soft, this is going to come down. The internal anal sphincter is going to go, oh, it's there, and it's poop, and it's going to keep coming. Okay, we can't postpone if there is weakness in your external anal sphincter, or if your internal anal sphincter isn't talking to you correctly. Say there's been some radiation, there's been a bad tear, there might be some sensory changes in there that is impacting that. All right, can we hear it for our beautiful rectum? Thank you. All right, maybe not as good as your hand-drawn art that your 5-year-old helped you get on, but I'm a visual learner, so I like those things. So as PTs, our job is to look at the muscles and say, what's going on and how do we fix these things? So in general, big picture, if a muscle is weak, you saw that that angle went really straight, so there is a bigger chance of leakage. On the flip side, if the muscle's too tight, now we have a closed outlet and a really big kink, right? And Dr. Trivedi used that term, you're trying to poop against a closed door. Yeah, the muscle's too tight. So let's actually talk about what to do for those things. So let's start with fecal incontinence. Now, one of the things that both our docs have talked about here today is that stool consistency. You saw the lovely Bristol stool scales, which is great. There are some things that can make our stool too soft, okay? And that's when it comes in, internal anal sphincter says, it's there, but you can't postpone. The stool actually has to have some weight and mass to it to get that reflex to kick in to allow us to postpone. Okay, so it could be dairy, like we heard about. It could be food allergies that we haven't figured out we have yet. I had a lovely gal coming in that was having fecal leakage, and we finally figured out it was nuts. She would play tennis. She liked to be able to eat some nuts really quick after to give her some energy. She thought, oh, I'm eating these healthy nuts, good fats, like this is good for my brain, it's good for everything. Her body wasn't able to digest the nuts well. And so it was making her GI tract move too fast. She was getting really loose stool and she leaked. She just needed to stop having her nuts. She really shouldn't have needed to come see me for that. That seems like a pretty simple answer. This time of year, we also see a little more loose stools because stone fruits are big ones. Is anybody excited? My nectarine tree has like 300 nectarines. There's no way we're going to be able to eat them all as fast as they ripen. But when you eat a lot of stone fruits, those are huge softeners. Great if you're constipated, not so great if you have soft stool. Things like spinach are great softeners. So it may be that somebody really needs to pick through that person's diet who is leaking and figure out, is it something that you eat because you love it and you think it's healthy for you, but your GI tract is not doing the best thing for it? Okay, so we look at stool consistency. But then obviously we got to strengthen those muscles. We need really good closure of the anal sphincter. We really need a good kink in that system between the rectum and the anus so we don't leak. So we strengthen pelvic floor, we strengthen the transverse abdominis, we strengthen the bum, we strengthen our hip rotators and our inner thighs. Those are kind of the big group team players. The pelvic floor by itself, we love it. It gets a lot of press, but it really needs the entire system to be strong and for us to be able to manage those pressures well. Because even if your pelvic floor is strong and you go and pick up a 30-pound bag of dog food, or you pick up a grandchild who's 40 pounds, the pressure is going to go somewhere if your stomach, your butt, your hips are not strong enough to manage that pressure. It's going to shove downward to your pelvic floor. So instead, we have to really balance these pressures beautifully. Okay, so fecal incontinence tends to be the easier, the less complex of the two things for us to treat. Dr. Trivedi mentioned biofeedback. So we will put little external EMG sensors on the pelvic floor and be able to see the pelvic floor contract, which is really nice. That helps with that brain connection to get that visual cue of what your pelvic floor is doing, and that helps us strengthen. And then for constipation. So again, we start with stool consistency. What does it, are you giving me the hook? I have 2 minutes. My last slide. Isn't this good timing? Thank you. So stool consistency. If the stool is too firm, it's hard to get out. So we need a little more fiber. And you don't just need more fiber, you need more water if you are having more fiber. People go, oh, I'm gonna have all this fiber, and then they end up clogging themselves up. So we love fiber, but you have to have adequate amount of water as well. Now, you guys have probably heard about the rest and digest system and the fight or flight system, right? Our sympathetic and parasympathetic nervous systems. So when we have higher stress, we are living in our sympathetic nervous system, which is not great for digestion. So being able to help facilitate our parasympathetics, our rest and digest and hang out is really important. So we teach breath work, we teach relaxation training, we teach some meditation. It's really not foo-foo, it's really great for your GI tract. And so we work on that because we need that peristalsis kicking in and getting the gut to move. So something else we add in to patients is starting a morning bowel routine. So the best chance to have a good poop is first thing in the morning. It's 30 minutes after your first meal. Your descending colon helps you out. It has really strong mass movements to shove everything down when that happens. That means you got to eat breakfast if you're having chronic constipation. So we will have people, as soon as they get up, start drinking, because we have this another great reflex called our gastrocolic reflex, that when you swallow, your peristalsis starts. It says something's coming, move on down, right? The stuff in the stomach goes to the small intestine, small goes to large goes to rectum. It starts everything kicking in. So we start with hot fluid is helpful, a good fiber-filled breakfast, and then we teach how to do some bowel massage. So if you put your hands on your right hip bone in front, and you were to do little circles there, and you were to come all the way up under the rib, across to the base of the other rib, and then down, that is a bowel massage. And even if it's just light touch, you just want to sit here and rub your belly. It's like, it makes me think of my dogs, right, that are at home, are just like, scratch my belly. That will get peristalsis going, just some gentle light touch. So starting some of those techniques at home, hot fluid as soon as you wake up, nice, deep, relaxing belly breathing several times during the day, having your breakfast, doing some bowel massage, and going and sitting on the toilet. Sit. Don't peruse Facebook too long, but sit. And you can see a little bit this picture here that this is a squatty potty. Does everybody know about the squatty potty? Getting your feet up a bit helps relax that puborectalis that we have been talking about. So this position where your knees are up above your hips helps relax the muscles so it is easier for stool to get out. So we set you up with some defecation mechanics. Sounds very fancy, the way we sit on the toilet. We look at our diet, we work on relaxation, and then we may need to go in and do some internal manual releases on those muscles as well, if they are too tight. So those are kind of the big things that we try to address as pelvic physical therapists to be able to help people resolve their constipation issues. And I could probably talk about that for another 3 hours, but they will truly pull me off the stage here. So that's my conclusion. PT can help with these things. And our website is womensadvantagept.com. We do treat all genders and all ages. If you have any questions, and I am probably going to be bolting during the Q&A. I really apologize for that. My 16-year-old is getting an award at the volleyball banquet up in Redondo Beach, so I have to kind of jump on the road and get back there. I may try to stay for just a couple minutes. Thank you so much.
Was given to us tonight. Any questions? Any thoughts? Yes.
You mentioned fiber and water, but I've also heard of probiotics. Is actually necessary?
Yeah, who wants to handle that question? We've got.
I'm sorry, should we come up there?
Yeah, please, love it.
Oh, sure. Yeah, the question was, in addition to water and fiber, are probiotics a good thing to take essentially for maybe digestive health? Is that, yeah? Yeah, so that's a fantastic question. I get it all the time. There are studies out there in terms of where probiotics have been helpful. So probiotics in specific kinds of probiotics during a course of antibiotics or after a course of antibiotics may decrease the risk of an infection called C. diff, which is a bad stool infection that can happen when the flora of the gut is changed from antibiotics. There may be some small studies to suggest probiotics like Align may be helpful with constipation, but More often than not, I think I see a lot of my patients taking probiotics because they feel like, oh, I'm supposed to take probiotics. Like, because it's good for me, or I've been told it's good for me, or my neighbor's friend's dog's cousin told me it's good for me. So, my recommendation, because probiotics can be really expensive, and quite honestly, there's so many of them, and they're coming in like cooler and cooler packaging. So, I feel like a lot of probiotics are actually marketing. Not saying that probiotics may not be good, but it's kind of one of those things where the gut flora can change meal to meal, you know? So my advice is really think about if the probiotic you feel is helping you, like, hey man, I started this thing and I'm pooping better and I'm doing what Jenny said, which is, drink my hot water and like meditate on my tummy and like do this good stuff, and yeah, everything's working great. All right. But otherwise, there's no real magic probiotic. So I really say take caution, not only just with probiotics, but just supplements in general, because sometimes people can inadvertently be spending like $200, $300, $400 a month on this stuff, and a lot of it's marketing. Now, I will recommend probiotics, obviously, if I'm putting people on antibiotics or specific ones that may decrease C. diff risk. There's definitely probiotics that can be helpful for women's health with recurrent urinary tract infections, like different lactobacillus species. Oh, they're vaginal. Okay. Oh, okay. Well, defer to Dr. DeWinter for that. But I hope that answers your question. It's just like, really see if it's helping you. And the way you know it is you just kind of stop it and see, and then you say, okay, and then look at what specific probiotics may be within that one, because there are multiple strains. And if it's a single strain, for example, there's a probiotic that I recommend a lot called Florastor if I'm giving somebody antibiotics. And a Florastor is a probiotic yeast called Saccharomyces boulardii. Okay, whatever. Well, Florastor for one bottle, it's like $50. Okay. But if you look at the ingredients, Saccharomyces boulardii, you can go to Target, you can get for a lot cheaper. Okay. So, buyer beware. But I don't feel it's mandatory that people are on probiotics. But hey, if it feels like it helps you, great. But if it doesn't, probiotics may also make people feel worse. That's the coda on that one, yeah. Yeah, I think I would probably put that in the same category as well. Like some prebiotics are actually pretty good soluble fibers, like inulin, potentially, maybe like a soluble fiber. So again, there's no have to. These are not mandatory, but see how it makes your body feel. And how long does it take? I don't know, maybe a couple of weeks to kind of see. But if they're really not helping you, there's really no need to like be on them for most people routinely. Yeah. So the question is about SIBO and kind of maybe a long-term antibiotic course of treatment. So it's probably. Oh yeah. So SIBO is small intestinal bacterial overgrowth. It's where the bacterial makeup of the small intestine is a bit altered. And it can cause symptoms from abdominal pain to bloating and brain fog and diarrhea and a host of other things. Yeah. So, again, great question. I'm going to relate it back to pelvic floor because the kind of talk was about pelvic floor. And that my belief in terms of SIBO is like everybody has it, just at variables. Like some people will be more gassy than at other times. Some people will be more bloated, more diarrhea at other times. So I guess my belief is like everybody has SIBO to some degree. And some people are more variable than others. And if some people seem to have more of this chronic SIBO where the bacterial makeup of the gut is just always seems to be altered because there's always GI stuff, the main thing I always think about is, are you pooping enough? And when it gets to the pelvic floor is, remember that definition of constipation where everyone's definition is a little bit, I've had so many people where I've had to get x-rays where they're like, no, I'm not constipated. And I show them the poop. Exactly, Dr. DeWinter. I show them the poop. I show them the x-ray. It's like, you're FOS, which is full of poop. So, as it relates to pelvic floor and SIBO, I would say my first thing always is presuming that somebody is not emptying all the way until proven otherwise. Because my feeling is that if you're not going to empty all the way, you can give antibiotics, you can give all this stuff, but it's just going to come back. And SIBO, most of the time, does come back. But if you're emptying and being able to clear that, whatever, then I think you'll have maybe potentially longer periods of more relief. So.
Agree. I put people on long-term antibiotics sometimes for bladder infections, and sometimes I'll have them take probiotics if it helps them. Usually we choose things that are really narrow to the gut that don't really affect the GI tract as much. So I haven't had issues, and I have a lot of women that have taken either months or years of antibiotics, and actually their bowels do okay. So it's just depends on your body and what you eat and what the variety is and that kind of thing, in my opinion, but yeah. We don't have a shared space for it, but absolutely, like we refer to each other constantly and make sure that our plans are coordinating with each other. There's colorectal surgeons as well on our panel for the Pelvic Health Center. And so there's some conditions for women especially that I'll operate at the same time as a colorectal surgeon, and we'll do procedures together. Rectal prolapse is the biggest one for that. And so we'll do a repair at the same time. So you don't just fix one compartment and leave the other one to get worse, right? So there are definitely times for that, and we've worked together on patients.
Yeah, I mean, we, in the pelvic floor center, I mean, we have, we contact each other all the time. And when I'm sending a referral to Dr. DeWinter, I send her a message and I call her. Sometimes if we need to talk mutual, I have patients likewise with her. So, yeah, so it winds up being informal. There's not like a Mayo Clinic, like sit down with multiple specialists, but we do a lot of patient care coordination between people referring back to each other. Oh, yeah, so my gut is off. Where do I begin? Kind of like that? Oh, well, like pelvic pain.
That's a good question. That's actually correct.
Call 1-800 Health. No, whatever the Pelvic Health Center is on the phone. Yeah, Dr. DeWinter, you want to?
No, for men or for women, they're going to orient you to the right people. Your primary care doctor may know some things about that. For women, we're really, really attuned to pelvic pain, and we get people to physical therapy very quickly. There's a whole slew of things that we do, but I think for men, it may be less of it's a harder path to find a pelvic floor physical therapist, because I think not all primary care doctors know that that's a resource, and they don't take care of it as often. I think urology is sometimes a good place to go. A lot of urologists will have an understanding of the pelvic floor and pelvic pain and chronic conditions there, and they know about pelvic floor PT, so sometimes urology is a good move. Yeah, you can call the line and they'll get you in touch based on your insurance of what's available to you, which of these providers take your insurance that you can go see and help coordinate to get you an appointment. There's sort of like a liaison person on the main line that will find that, like, you give a brief description of your symptoms to, and then they'll get you to the right place. And sometimes if they need referrals, I'm sure we can refer to physical therapy is incredibly helpful. Usually you have to see a doctor first to get a referral for physical therapy if you want it to get covered by insurance. There's a whole lot of really good pelvic floor PT places that take cash, but it's expensive. So Women's Advantage, for Jenny Gablesberg that talked, like they take a ton of insurance plans. So they actually, like, you can do a copay like you normally do for like a shoulder, but there's a lot of out-of-network places that you can use your insurance benefits on, or your FSA, HSA money kind of on directly, and they may or may not necessarily need a direct referral kind of a thing. But
hi, I'm back. My name's Katie. I'm a physical therapist. I work at Long Beach Memorial. We have our own set of pelvic physical therapists. For the hospital-based program, we do require the physician's order, so it's best to go through the Pelvic Health Center. The nice thing about the center is, as they were describing, there's providers that accept insurance, and then some that are out of network providers that are cash-based, but they take all your information and then they'll give you the providers that you have the option to go to. And that's kind of nice, just that you have the choice. So it's not directing everyone just to the hospital-based program. So you can peruse the websites, you can kind of see what is the best location and what works best for you.
The big idea is to have someone who is specifically trained in pelvic health.
Mm-hmm.
You were referring to, I'm in a position where I have a Medicare patient.
Okay.
It limits things.
Yeah.
Obviously, you got to get ready, but as long as it doesn't.
Yeah, I can speak for the Memorial Care program. We do accept Medicare, HMO, so that's a really great thing. Our program is new, it's just about a year old. And it's something I was really passionate about, just increasing the access of care for people to use insurance to access pelvic health services, because there are a lot of clinics that don't accept insurance. So I'm really happy we're just opening up more opportunities for people to use insurance for care.
Well, I mean, the question was, is there a number of normal bowel movements a week? Well, the textbooks may say, 3 per day to 3 per week or something, but that's all relative. It's really like, are you uncomfortable? Like if some people have they go once every 4 days, and they're not uncomfortable. Most people would be, right? But they're not uncomfortable. They go, and then when they have a movement, it's big and it's complete, and they're not clogging anything, and they're not tearing anything, and okay. Or some people go 4 times a day, but it doesn't affect their lives. They don't have urgency. They're not running to the bathroom. They're not leaking, and so it's I think we all want to be normal because we don't want to be broken, but hey, we're all broken, so I'm just kidding. Yeah, so it's really, is it make you uncomfortable? I mean, in general, I mean, look, it's not like your colon cancer risk is going to go up if you poop once every 4 days. Okay, I don't think that really has been proven. So it's really, a lot of GI is really, does it make you feel bad? When it comes to symptoms, and it's like, yeah, I kind of feel okay. Well, then there you go. That's okay.
Yeah, let me just finish the Zoom if you don't mind, just because we had a question about, does age have something to do with fecal incontinence in women?
It does in some different ways. So you kind of have like 2 peaks, right? When you're kind of young and having babies, a lot of women get fecal incontinence, and then it may get better or worse or stay the same over time. And then as women sort of get into their 70s, 80s, 90s, when they more mature, they start losing a little bit of muscle mass. So when you lose teeny tiny amounts of muscle mass in somewhere that has these tiny delicate anal sphincters and these pelvic floor muscles that are very thin layers, even a little loss of muscle ends up being a big loss of control in some women. Not everybody gets it when they're older, not everybody has it, but that's one of the things. And constipation gets more common as you get older. So constipation and loss of muscle kind of work together, so everybody ends up having a little bit more of it when they come into their older years. Yeah, for sure. It absolutely can. So if you've had a birth injury, there's different varieties of birth injury. Sometimes it's just the skin, sometimes it's just some of those pelvic floor muscles that are supportive, and then sometimes it cuts all the way into that anal sphincter, the psychedelic one. So if it gets all the way through, that's when you really get bowel issues, and they can start manifesting kind of around menopause or a little bit after, when that loss of estrogen and changes in your tissue in that area start flaring up. So some women will have a bad injury and they'll be able to maintain it and control their bowels enough, maybe occasionally have a leak, but when they get into menopause and get a little bit older, those old injuries can sort of come back again and start bothering people. Absolutely. So the question is, how much water do you need to drink in a day, and does it need to be water? We may have 8 different opinions between the 3 of us, to be honest. So my usual thing is 6 to 8 ounce glasses of water if water is your choice. But anything that you drink counts as water. Your good body is going to process it as water. So if you drink a soup and it has a bunch of water in it, like you're gonna pee more because it got that water into your system. In my opinion, it absolutely counts. What about y'all?
Yeah, so I'm a big podcast guy. So I heard a podcast recently. That I'll vouch for it. It's called, or I'll plug it. It's called Plain English, this is one of the things that they're talking about, right? So yeah, you heard this 8 glasses of water a day, but Coke doesn't count. Diet Coke doesn't count. Yeah, so pretty much very convincing evidence that was presented, which said that we have a mechanism in our bodies to keep our homeostasis, which is balance. All right. So when we need to have more fluid, we'll get thirsty. Now that being said, if you just drink maybe 3 ounces of water a day, that might be enough to sustain life, maybe. And your pee might be really concentrated and yucky, so that's probably too little. But I don't think one needs to sort of force themselves to be on this 8-glass regimen. Vegetables, for example, a lot of water-containing vegetables, or things like for people who drink milk or whatever, milk, plant-based milk, or teas, or I even heard, and I haven't done the research on this, but there may be some evidence to suggest that if you have water and you put a little bit of salt in it, maybe actually enhances the absorption of the water. So no, you don't have to drink 8 glasses of water a day. Yeah, but if you're not pooping enough, if you're constipated, if your pee looks like Diet Coke, yeah, you should probably drink a little bit more water. Oh, it's called Plain English, yeah.
So the brand name that's marketed is the Squatty Potty. They did a really good job of just coming up with that name. But really, any step stool that's placed on the floor that's going to bring your knees up higher than your hips with your feet supported helps to just put your rectum at that better angle for the poop to slide out. Can be very effective for people.
And it doesn't count just to pull your legs up. I've had people ask me that.
Yeah. So like the cheap version of just putting like your heels up, that's actually activating your muscles through the legs. It's not going to have the same effect and allow everything to relax. Yeah, holding your feet up in the air, you really need the support where everything can relax.
Yeah, it'd be really interesting to see why, like I haven't looked at the history of the toilet, because ergonomically, the toilet is not really ergonomic. I mean, if you look at India, Southeast Asia, a lot of Africa, I mean, everybody squats, I mean, yeah, so anyway. Okay, so the question is about clothes and constraining clothes, about affecting bowel movements, and the second question about just sort of wiping behaviors, and can that affect, can you clarify your second question? I'm sorry. Or the like wiping a lot, is that a problem? Is that kind of what you, how you do it, okay. I will, so as far as the clothes constricting, I think, if people are really bloated, I mean, I don't know if it would really prevent bowel movements, but I would imagine if people were really bloated, let's say a lot of, and their stomach was kind of pooching out because they're really backed up and constipated, they would just be uncomfortable. But I don't know if that would really restrict a bowel movement. Maybe in terms of breathing as it relates to pelvic floor stuff, it may. I don't know if you want to talk about that.
Yeah, I haven't seen any specific like research or through my training about clothing specifically restricting bowel movements, but as Jenny was talking about, having what we call a diaphragmatic breath, and when we're allowing the belly to expand sides of the ribs and then chest, is really important for maintaining that pelvic floor relaxation. So if you are wearing overly restricted clothes and never breathing, allowing your diaphragm to really drop down, pelvic floor to drop down, that could lead to the pelvic floor tension And then that could potentially lead to some issues with constipation. So in a roundabout way, it's a possibility. I would focus on clothing that just allows your belly to expand and fully breathe. That's good for overall health and wellness.
So I'll make a brief point on the second thing. No, it's not like wiping a lot after you have a bowel movement to get clean is bad. It's just it may be reflective if it's a problem for the person. It may be, so for example, if it may suggest, number one, the stool is really mushy. So maybe there needs to be some additional fiber that's added so that the movement can be a bit more complete. What I see is people will wipe a lot, especially with toilet paper, and be very abrasive to the delicate tissues in the perineum and the area around the anus. And that can cause tenderness, it can cause pain, it can cause bleeding. And all those things can affect the function of the sphincter, because then the sphincter will start to squeeze and contract and not relax appropriately, and then you'll start pooping against a closed hole and then kind of run into upstream issues. The other thing where one has to keep on wiping a lot, especially in women, and if they're older too, I'm wondering if that might potentially make one more prone to UTIs just because of contamination. I like bidets because, they kind of allow you to clean up and then use minimal abrasive friction in order to get clean. So.
Thank you so much. Dr. Trivedi, we just want to thank you. Katie, thank you so much for being here.
Being a
for
rep.
We just want to thank all of you for being here and taking the time. We so value your feedback. There is a questionnaire. Just love that feedback. Also, too, that this is a value for you. What topics would be of interest? So please let us know. Our speakers will be here for a little bit afterwards. If you want to talk to them one-on-one, I'm sure you'll be pleased to. But again, thank you very much. Enjoy the rest of spring. Ideally, we're going to get rid of this gray and enjoy summer, but thank you all very much for coming tonight.
Jennifer.